Good morning, everyone. Welcome to the Hindu's Wellness Series webinar. This edition is being presented by Apollo Hospitals along with the Hindu. The webinar is on robotics and minimally invasive cardiac surgery, the no scar heart surgery. The webinar will be presented by Dr. M. Yusuf, a senior consultant in cardiothoracic surgery at Apollo Hospitals, Chennai. He is a globally renowned specialist in robotic cardiac and a robotic cardiac surgeon. He is one among the few surgeons in the world performing total arterial robotic CABG, coronary artery bypass surgery. He also specializes in hybrid coronary revascularization, minimally invasive valve repair surgery, and complex aortic aneurysm repair surgery. Dr. Yusuf underwent training in minimally invasive and robotic cardiac surgeries in Belgium, and after 2 decades of experience in prestigious institutes such as St. Bartholomew's Hospital, the King's Hospital London, and OLV Hospital Belgium, he has returned to serve and work in India. Welcome, Dr. M. Yusuf.
Good morning.
Thank you for joining us, sir. And I would like you to start with your presentation so that people can join us after your presentation is done, and we will have a small discussion, following which we will take question and answers from the audience.
Sure. Thank you. Good morning, everyone. I thank Apollo Management Marketing Team and Hindu for creating this good platform and giving me this opportunity. I'll start off with my presentation. Can you see?
Yes, sir.
So cardiac surgery is basically for all these common problems, which majority is coronary artery disease surgery, valve disease problems, mitral, aortic valve, tricuspid valve, and disease of the major blood vessel aorta as well. So almost all of these surgeries in most of the patients can be performed now through minimally invasive surgery. So looking at the epidemiology, why is it very important in our country? Almost 50% of the world's coronary artery disease population is currently in India. That's since 2020 survey. So why is it? Mainly because of a change in lifestyle and food habits. In fact, we have taken the best from the Western world and also lost our roots. So we have to, with the economic progress, we have become less exercise related activities. We have reduced our exercise by just getting on, hopping off of vehicles, and also taking nutritious rich food with even less activities. So junk food has also become a major player in this. For this reason, we are seeing more coronary artery disease in young patients, unfortunately, in our country. In the Western population, it's predominantly over the age of 65. But in our country, more than 50% of the patients are within the yearning group, 45 to 60. So that's mainly due to our adapting poor lifestyle and poor food habit measures, which we have to go back to our roots and also change in our pattern of running around with a stressful lifestyle. The common risk factors for coronary artery disease, major cardiac problems are diabetes, which is very prevalent in our country, blood pressure, high cholesterol, smoking, and family history. Of these risk factors, we cannot change much about family history, but smoking, yes, we can completely avoid. High cholesterol, high blood pressure, diabetes, we can modify by modifying our lifestyle and food habits. How do we prevent these problems? As I already said, in patients who have diabetes or family history, it is very, very important, do not smoke and have a reasonably healthy lifestyle, including activities such as walking or jogging in our day-to-day lifestyle, and having a master health check once in a year or once every 2 years from the age of even 30. So patients who have early diabetes and family history, it's better to have health checks regularly, at least on 2 yearly basis from the age of 30. It is important to control blood pressure and control cholesterol. Increase activity. It is good to have some activities on a permanent and inclusion basis. Say, like if you're going to work, try to walk as much as possible, try to avoid lifts at work, all these measures. So for secondary prevention, if someone has developed coronary artery disease, it's important to have three things. Lifestyle measures, which I said, less stress and activities such as walking or exercise. Sensible eating. You don't need to be on diet, but less fatty food, less oil, less fried items, and tablets for life. There are few tablets, antiplatelets, which reduce blood or keeps the blood thinner, anti-cholesterol tablets, anti-blood pressure tablets. These are the usual tablets following coronary artery disease. So these three things are important: lifestyle measures, sensible eating, and tablets for secondary prevention. For primary prevention, avoid these problems before they're coming out. So these are quite important to take control of our body and avoid cardiac problems and prevent seeing surgeons like us. For treatment of coronary artery disease, the indications are currently either medical management only in the early phases, but once coronary artery disease is noted or diagnosed, then either PCI stenting or coronary artery bypass graft surgery. So in single or two vessel disease, with or without disease in the proximal segment, stent still holds good. But surgery holds good for these patients as well as in patients with multi-vessel disease in the left main coronary artery. The coronary arteries, there are three in the body, two on the left and one on the right. The left system comes as one and then divides to two. Before it divides is called the left main stem. Any disease in that or in multi-vessel patients with multi-vessel disease and especially diabetics, surgery holds better on short and long term. In patients who have single or two vessel disease, non-diabetic, then stents are better. So this is how stents work. Basically, we put a catheter through the blockage. It has to go across the blockage and then open up a spring-like fold, which also has drugs eluting from it in the newer generation stent. It stands good in minimal coronary artery disease, single or two vessel disease. And as I said, CABG holds good for multi-vessel disease in diabetics, patients with reduced heart function, patients who have recurrent blockage in the stents, or with severe significant disease which has a scoring system of a syntax. So these patients, it's better to undergo surgery, especially in diabetics, which is quite common in our country. The main scare of cardiac surgery was splitting the central chest bone, splitting open the chest, and then the related slow healing process and the slow rehabilitation involved. Patients normally take about 3 to 4 months to get back to normal activity. It is the fear and the morbidity related to that. Also, patients, when we started cardiac surgery for both CABG as well as valve surgeries, we needed to stop the heart, place them on the heart-lung machine, which will take over the job of the heart and the lung while the heart is stopped, and then we have to restart the heart. That has negative effect on the lungs, kidneys, and so on. We have moved out from that gradually over time. Now for coronary artery bypass graft surgery, which is the commonest procedure performed in our country, we don't need to stop the heart. We can perform surgery with the heart beating, which is performed in most places. With more expertise, we have moved on further to perform minimally invasive cardiac surgery, where the sternum is not split at all. We make tiny holes along the chest and then do the procedure as required. So this was the initial definition of minimal invasive cardiac surgery without splitting the full chest bone, either partial or cut on the sides of the chest. Again, with increased expertise and over a period of time, since 1970s, we have been performing coronary artery bypass graft surgery. We have moved on to do true minimal invasive surgery with through small pinholes, either using video strip thoracoscope and now with robot assist. Robot has really paved the way over the last decade to make it much simpler for the patient and the surgeon with extremely quick recovery, avoiding chest bone split and also avoiding big cuts even in the side of the chest. So now we are able to do mitral surgery, valve repair surgeries, and coronary artery bypass graft surgeries for single, multiple vessels through robotic assist. Valve repair is always better than replacement because it's patient's own native tissues. It lasts longest, and because any man-made valve doesn't have the life of our own tissues unless it's a mechanical valve where they have to take blood thinning tablets. So the valve repair avoids all these anticoagulation risks as well as risk of reoperation. So best to repair whenever possible. So we can repair valves through robotic surgery as well. So that's a picture of a mitral valve surgery where you see a tiny 5 centimeters cut with 3 pinholes aiding the camera and the hands of the robotic arms going through. So we can perform all these procedures through a right tiny cut right robotic approach. Mitral valve repair, replacement, atrial septal defects repair, right or left atrial tumors can be released, and tricuspid valve repair or replacement. CABG, usually cut is made on the left side of the chest. Now we have moved on to do more bilateral arterial grafts where we make holes in the right and left and tiny cut in the left side through which procedure is done. So we started off with single vessel disease. Now we are able to treat double and triple vessel disease by combining stenting as well, which is called hybrid approach. I'll talk about it in a couple of slides next. So that's how the robotic surgery works. Robot doesn't do the surgery on its own. It is guided by us. So the surgeon, we sit in the console looking at the patient through this. So it is 10 times magnification to the normal eye. So we get extremely high precision and hardly any blood loss. So we operate the robotic arms through our fingers. So you can see the patient is lying there, robotic arms are passed through pinholes. So that's how we are able to do the procedure done inside the chest is exactly the same as open surgery, but without splitting the sternum. That is a huge advantage by performing through robot. And the precision, as I said, is very high. So that's at the end of the robotic arms when they are removed 3 pinholes. The mid hole is then extended to 5 centimeters to perform the anastomosis under direct vision. We can also do this with robotic guidance. So that's how much spread it's made between the ribs, just 5 centimeters, and you see the anastomosis very clearly. Now, as I said, we are able to use both arteries. Using arteries to perform coronary artery bypass grafts is much better than using veins from the legs because the longevity is great. All studies have shown, I'll show you a couple of slides later, it has the best longevity. So we can use 2 arteries from the chest wall, and for the third, we can use the artery from the arm. Even that we are now doing through an endoscope, so without cutting. So everything is done through pinhole, and we are one among the very few centers in the world doing total arterial robotic coronary artery bypass graft surgery with good outcomes. So these are the advantages of using the robot to assist. So as I said, it has a 360-degree arm movement, magnified vision, there's no tremor, and hardly any blood loss and pain. Usually patients go home in 48 to 72 hours and return to full normal activity within 2 to 3 weeks. The disadvantages are it's a longer learning curve. There are very few surgeons like us trained in the world, and it is slightly more expensive. Roughly, it is twice the cost of open surgery. But economic survey done in the US have shown over a 6 months to 1 year period, this is more advantageous in economically as well to patients than open procedures. It is more so in our country, as I've already said, most of our patients are in the earning group, breadwinners. For them, getting back to work yearly is very important. That way, our economic benefits may be even higher than what is in the US. It is teamwork. We have a fantastic team in our center in Apollo Greens Road. Not only teamwork, we also have the infrastructure to support. So all this needs, it's not just a one-man's job. We as surgeons lead the team and do the main job, but we need the full support of our anesthetist, cardiologist, perfusionist, scrub team, our physician assistant. They play a major role. I'm very grateful to my mentor, Dr. Frank Wantrack, who is in the picture with me, to have trained me. And also he came over here to start our program a few years ago. During the pandemic alone, we have done close to 100 surgeries because it's a contactless surgery. More and more patients do not want to stay in hospital too long during this period. It's really helped. There are certain contraindications, previous lung surgery, poor lung capacity, but now with hybrid procedures, we are able to perform more and more procedures, which would have otherwise not be able to do with one or the other, either PCI alone or robotic alone. So this is a couple of evidence to say robotic surgery is much, initially it was shown to be less inferior to open procedures, but now it increase quick recovery time and short hospital stay. Not only that, recent studies in the May 2020 review article has shown, this is from a major journal in cardiology, Journal of American College of Cardiology. They have shown there is less mortality as well. Recently, in the last two review articles in 2020 and June 2020 as well, they have shown clearly that it is now becoming superior to open surgery with less complications. So this was about 1,000 patients following mitral valve procedure. And further, they have looked at CABG, comparing open CABG with robotic assist. Over a 12-month period, there was reduced incidence of complications related to cardiac surgery, major adverse cerebrovascular and cardiac events, and mortality as well. So they concluded there is improved advantage with less risk of graft inclusion or major cardiovascular events. So now we have moved on to hybrid procedures, as I've already said. So for multi-vessel coronary artery disease, especially in diabetic and in patients with high comorbidities, especially elderly with higher comorbidities, and in young who need to return to work very early if the heart function is poor, we are able to combine the advantages of robotic minimal invasive surgery as well as stenting. So the left-sided system, which is supplies blood to the pumping chamber, we consider them as more important. We are able to perform single or bilateral internal mammary artery procedures to them through robotic or minimal invasive procedure, and the right-sided coronary artery is stented. So that way we work together with cardiologists and give the best outcome. We are one of the few centers in the world and one in the country doing the highest number of hybrid procedures. So the advantage of, as I've already said, is because of the arteries, time tested, most studies have shown the arteries are patent, 90% of the arteries are patent over 20 years. With single, as well as the Cleveland Group have shown looking at over 6,000 patients. Again, the survival advantage, reoperation rate are much less, 20 years survival and patency is more than 90% by using more arteries. That's the reason we are combining the two, using more arteries, and vein grafts don't last that long. In fact, the newer generation drug-eluting stents are far superior in the 1-year outcome compared to vein grafts. So that's what we are doing the best of both worlds, giving less morbidity, early recovery, and good long-term outcome to the patient, like increasing the patient's two-stage approach. The added advantage are technically, we do the surgery first. The second post-op day stenting is done, where the cardiologist can do even complex stenting if required, and also it avoids any bleeding related to surgery. They always we check the bypass procedure by shooting them as well. So that way it is reassurance to the cardiologist, patients, and the surgeons to make sure what we have done during surgery is working well. So these are the advantages. It avoids splitting the chest. It's a two-stage approach, avoids any bleeding complications, and gives best outcome to the patients on the short and long term. So that's a couple of patients. You can see that for doctors who are watching, that's the left main stem, which is nasty, and there is no flow in the left anterior descending artery. So the stent is placed from the left main stem, beautiful flow. We also check the LAD flow to the, left internal mammary artery flow to the LAD, which is beautiful. That's at the end of the procedure with a 5 centimeters cut and a drain, which is removed the following day. So this is bilateral internal mammary artery, one flowing to the circumflex, the lima flowing to the LAD. It's a beautiful flow. That's at the end of the procedure. These we usually tend to do with with robotic, where both arteries have their native flow, which tends to have even better patency. Advantages: we can treat more multivessel patients, diabetics, and especially elderly high-risk patients, with all the other advantages of minimal invasive surgery, with less blood loss, short hospital stay, and the early return to normal activity within 2 to 3 weeks. So this was a Chinese study where they clearly showed in the high Euroscore group, which is a scoring system we use to classify risks following coronary artery bypass surgery. If the score is high, above 5, it is considered high score. In this group, when they compared hybrid versus open CABG versus multivessel stenting, they noticed the hybrid group, where internal mammary artery plus stenting is combined, they have best long-term, short-term and long-term outcome, with reduced incidence of major adverse cerebrovascular and cardiac events. So we are able to treat patients with poor LV function, even with chronic kidney disease, poor mobility. We have seen a lot of elderly patients go home well by combining this. So this was the recent review article which I discussed about, published in August last year in same Journal of American College of Cardiology. They showed, compared to CABG and multivessel, where in CABG incidence of major adverse cardiovascular events in the early phase is higher, whereas with multivessel stenting, the delayed outcomes are not great. It's increased incidence of major adverse cardiovascular events. With hybrid, both of these are good, with excellent short-term and long-term outcome. So they concluded in the editorial formed in Circulation, which is a major cardiology journal, that this has a good financial benefit and excellent recovery, but should be performed in centers with trained surgeons in minimal invasive and robotic surgery, and good integration between cardiologists and surgeons. We always involve the patient's family in the discussion before taking patients for hybrid procedures. So this we have already discussed. Thank you. Now we can go on to question and answers, please. Sorry, we can't hear you.
Yeah, thank you. I'm sorry, I had muted myself. There are a few questions here. Yes. And the first one is from Ponnammal Vikraman. And she says, thank you very much for conducting this type of webinar. What about the cost of this type of surgery for heart patient that a heart patient will have to pay?
So as I said, it is approximately twice the cost of open surgery. So open surgery will be roughly 3 to 3.5 lakhs. This is between 7 to 7.5 lakhs, around 7.5 lakhs in our center. So it is approximately twice the cost of open surgery, because we have to use the instrumentation, the robo, and everything. But as I said, the advantages and considering the recovery, the economic benefits have been huge in all studies that have been conducted in the Western world. We are also in the process of conducting a study which will be publishing in the next few months.
Thank you, sir. The next question is my father has been, this person, her name is Anita. My father has been suggested CABG with grafts to LAD, diagonal QM, and distal RCA. Is minimally invasive surgery possible for my father's condition? Please advise.
Yes. As I said, we need to individualize patients
And
here. We
excuse me,
see,
there's one more thing. He said
yeah,
he's chronic diabetic.
yeah, the diabetes. So that's not a contraindication. We generally look at the angiogram, the echocardiogram, and the patient as a whole to assess fitness. And now, most patients, by combining this hybrid procedure as well, most patients are fit to undergo these procedures. So we need to see the patient depending on the anatomy of the disease. Yes, possible. If the heart function is reasonably good, we can do them all robotic. If it is low or poor, then we may have to combine it with sending to the less important vessels as a hybrid.
Uh, Here's one person, he's an anonymous attendee. He says, I read on your poster that you can discharge after 2-3 days. This sounds so unreal after heart surgery. Are there any caveats to this discharge time?
No, you can see our patients, talk to them. That's all I can say. So that is the usual. We don't say something that we are not practicing on a day-to-day basis. If the patients have, as I said, the higher morbidity group or the hybrid group, they may have to stay 1 or 2 days more. But patients who have if it is a single vessel robotic procedure, they go home in 48 hours, most of them. And if it is multi-vessel, they go home in 3 days. So that's our usual routine.
How about the cost when compared to normal? I think we've already, and normal
Yeah.
surgery and stay in the hospital, we've already answered that question. Or lots of people have asked about the cost.
Yeah.
Then
So we do notice that. So during the pandemic, or now people are slowly getting aware of this robotic procedure. Because as I said, in the country currently, we are the only center doing this routinely. So that people are now getting to know about the robotic procedure and the advantages, mainly through patients and some of like you have helped today to make more people aware. So most of the patients that walk into my outpatient ask, Doctor, can you do the robotic? Yes, it is possible in most patients, as I said, but in some patients, very few, it may not be possible, where we still do open procedures. End of the day, two things are very important for the patient: immediate safety and long-term outcome. These two have to be in place, which we do not compromise on any account. If we cannot do a minimal invasive or robotic procedure to not achieve any of these two, then we perform open procedure, which is in very few patients these days. And some patients may not be able to afford as well, in which case we have to do open procedure.
so this brings us to the next question. How is not cutting the sternum an advantage?
Yeah, I mean, cutting the sternum is cutting the bone. It's splitting the chest open. So that is the biggest morbidity and fear of heart surgery. So that's the reason patients would twist the cardiologist's arm to do stents, even when they say, no, it may not be best on the long term in some patients, multivessel. So the major morbidity is because the bone takes 3 months to heal, like any fracture. So until then, they have to have a restricted lifestyle. Of course, related pain, everything is there. So because it's a big cut, there is a related pain along with it. So the trauma to the body, any major cut has its own immunomodulation. The immunity is reduced during that time after any major trauma. In a rough or layman's term, we usually tend to say going through an open heart surgery is like undergoing and recovering from a major accident. So that's how much the trauma is to the body. So the body has to recover from the trauma, immunomodulation, and the systemic immunomodulation and the systemic SIRS, as we say, systemic immunomodulation response activity. So that causes systemic response like any shock. So all this has to be recovered from a major open heart surgery. By avoiding the big cut in the sternum, the whole trauma is reduced to a significant extent. It's not complete because what we do inside is the same. So there will be a bit of trauma involved, but it's, I would say, about half of what we would be with open surgery. That's the reason recent articles have shown it to be superior to open surgery. Because previously it was all the learning curve of surgeons. Now most of them have come off the learning curve, and since we are doing it routinely, we are able to give it with better outcomes. It's like that's the reason I showed some slides to how we have moved from open, stopping the heart, beating heart, minimal invasive, and now with robotic. So it is the progress with technology and patient's demand.
Thank you, Dr. Thank you, Doctor. Here is the next question. Please, can you elaborate on whether robotic surgery is safer than the other procedures? Why are there not many centers in India that do this?
I think you already discussed it.
Yeah, you already discussed it.
Point,
There's a lot of
so it is lack of trained surgeons. So it takes longer training. As I said, if you look through my profile, I had taken a year off to train in robotic surgery alone after completely training in cardiac surgery. So, and I had the opportunity having been trained in UK, but I had to wait for 3 years to get on to that training. So it's a longer training process, and you need all the infrastructure and the support of the team as well, which is not available in most centers. So that's the reason it's not available everywhere. It needs investment by the management and the hospital. It needs expertise, and it needs good team support apart from the expertise and training. So all these three have to work together. So that's reason it's not available everywhere. And all these three are very important for the good outcome. It's not just the surgeon alone. We have an excellent anesthetic team along with the cardiologist, theater team, everybody.
Thank you, sir. So here somebody is asking, what are the side effects of this surgery?
Side effects are actually less. One side effect I would say is cost. It is more expensive. And even in the best hands, if, as I said, if there is any compromise on safety, sometimes manipulating the heart within the closed chest, sometimes there may be hemodynamic compromise, blood pressure, the heart may not tolerate, even though we assess everything. That happens in 1 or 2 in 100. So that if that scenario happens, then we may have to open the chest and complete the procedure. So the one side effect may be you might have an extra pinhole along with the open procedure. So that's a minor side effect because that pinhole is only 5 centimeters. It may not bother patients at all. There is not much side effects. It's more benefits than side effects by this procedure. And as I said, in 15 to 20% of patients, we may not be able to offer this due to various reasons. Mainly the heart function and also the anatomy of the vessels. So almost 80% we can offer.
Thank you, doctor. So there's somebody is asking, after the surgery, what are the things we are not supposed to do?
After open cardiac surgery, I think we all know, so it is a longer procedure, but with our following robotic or minimal invasive procedure, first 2 weeks, when they go home, we'll be able to get them walking, stair climbing, everything. And when they go home, we will be telling them to get back to their normal activities within the house. First 2 weeks, we generally advise them not to go out due to infection risk or being exposure. Because although I said it reduces the major trauma, but there is trauma and less than the open procedure. So that's first 2 weeks, we advise them not to go out. But once they come and see us in outpatients after 2 weeks, we make sure wound is healed, everything is fine. Then they can go back to slowly full normal activity. They can get back to work, driving, everything within the following 1 to 2 weeks. Which in open procedure, take slowly over a period of 3 to 4 months. That's the difference. At the end of 3 to 4 months, both are the same. The long-term outcome is the same. It is a short-term benefit, which is huge because we avoid the full split of the sternum and the systemic inflammatory response related to that.
So, doctor, there is this young girl. She's a student from Christwood School. She's in grade 10. Her name is Kavya. She has a question. Can we use saliva of leeches to thin the blood instead of pills?
That is a good question. I think you've read somewhere. There is the leeches have an anticoagulation effect. Yes, but we don't use that. I mean, it's not medically possible. That's the reason in valve replacement patients, we tend to use anticoagulation tablets, coumadin derivatives. They're either warfarin or acetone. So leech has an anticoagulation effect, but that is not used medically. So for anticoagulation, but for coronary artery disease, we tend to use antiplatelet tablets, which prevents platelet adhesion. So the actual pathology in coronary artery disease is, since she is asked a knowledgeable, it's a question which she probably has read in the books. I will answer it to her with this. So antiplatelet tablets prevent platelet adhesion. So they keep the platelets away from, prevent adhering them to each other. That way they thin the blood. But the anticoagulants keep it thin in a different pathway. So these ones in coronary artery disease, the pathology is when there are cholesterol plaques attached to, they form on the blood vessels, the internal layer of the blood vessels, then platelets tend to adhere here, and that increases the blocks. By keeping the blood thin with antiplatelets, this is avoided. And we also start these patients on anti-cholesterol tablets to prevent these cholesterol plaques from forming. So these are the two medications that we put them on. Patients who have any coronary artery disease, we put them on for lifetime. But one thing I have to mention here also is this stenting or surgery, whatever we do, prevent or treats the problem that's already risen, which is the blocks. But the disease process is usually in this patient's body once they start. To prevent or reduce the progression of the disease process, they have to be on tablets for life. 2, or as I've already said, antiplatelet tablets, anti-cholesterol tablets, and anti-blood pressure tablets. Some other tablets to help the heart function better. So these things really help in reducing disease progression. So as I already mentioned in my presentation, patients who have coronary artery disease should take tablets for life. It's not like other procedures where they treat the problem and it doesn't happen. No, they have to take tablets for life. They have to have a healthy lifestyle, but they can lead a normal lifestyle. Do not think patients having cardiac surgery should end up with their life. No, the main reason for doing cardiac procedures, either stenting or surgery, and especially by doing minimally robotic procedures, is to get them back to their normal lifestyle and activity so they lead a normal life, which is very much possible in most patients. So please don't keep them at home. Normal lifestyle, tablets, and sensible eating. With this, they can lead a normal life.
Here is one person called Radha Krishnan Ramasamy. Sir, I am aged 50 years. I was having hypertension for 6 years, maintained BP normal with Cobcor and Coversil tablet. And in CT scan found normal and BP is normal. Now I have reduced the weight from 105 kgs to 80 kgs, maintaining 24 BMI. Now can I stop or reduce my tablet intake? Please guide. So I think he wants to know if he can reduce the tablets.
It is good that you have done all that. It would be best for you to have a health check with a doctor, preferably cardiologist, to assess your cholesterol levels, to assess your blood pressure, and check your diabetic status if you have been. So if they are all within the normal range, then there is room for gradually cutting down the tablets and stop if possible.
I think you have answered this question, but I'll still anyway put it to you. Um, this person is again an anonymous attendee. He says he's very happy that we had this webinar, but with regard to valve replacement procedures, how can robotic surgery be useful, sir? What are the advantages over conventional methods? Do patients need to take coagulants in the long run? How long can a replaced valve last?
Yeah, okay. I think the first half of his question has already been answered, and we showed pictures as well. Yes, valve replacement procedures are possible, especially mitral valve are possible. Aortic valve as well, we are doing through minimal invasive. In aortic valve, we may not need robotic assist. More often, we don't need to. So most of the valve procedures as well, we do minimal invasive and robotic these days. I showed a picture of that. And yes, coming to coagulation and the longevity of the valves, that's something we didn't touch about. Of course, we touched coagulation. So there are two types of valves. So as I've already mentioned, whenever possible, we will tend to repair the patient's own native valve. So that is the best if we can have your own tissues last the longest. In a lot of patients, especially with rheumatic heart disease, we may not be able to repair the valve. And a lot of aortic valve patients. So those patients we will have to replace. There are two types of valves available for replacement. One we call mechanical, the other one is biological. The bioprosthesis or biological valve is a man-made valve. Both are man-made valves. The bioprosthetic valve is made out of either cow's pericardium, which is a covering of the heart of the cow, or which is treated and time tested, or it's taken from pigs and remounted. So these are the two types we call bovine pericardial valves or porcine valves. These two are the biological valves. The advantage of biological valves are we don't need to take blood thinning tablets. Just antiplatelets are fine. So the blood thinning tablets or the anticoagulants have a risk. So if we don't take them properly, they can form clots within the valve. If you take them too much, then they can cause internal bleed. So that anticoagulation can be completely avoided by using biological valves. But unfortunately, biological valves have a restricted lifetime. But now we are getting more and more better valves, where now we have a newer valve in the market, which lasts 15 to 20 years in most patients. So we tend to use them in the elderly population or patients above 60. But nowadays, with these newer valves, biological valves, we give the patient the option. I'll briefly mention about mechanical as well. The disadvantage of mechanical valve is they have to take this blood thinning tablet for life every day without missing. As I already mentioned, if they don't take the tablet, it can form clots because the mechanical valve have hinges like our door hinges. So they need to keep blood at least twice to 3 times thinner to prevent blood clots within the hinges of the mechanics of the valve. That is a disadvantage of mechanical valve. If they take the blood, if the blood goes too thin, then it can bleed, cause internal bleed within anywhere in the body, head or abdomen or chest, anywhere. So, but the advantage of mechanical valve is it tends to last for life because there is no biological material which can disintegrate with time. So these are the two types. But with the newer generation biological valve, which tends to last 15 to 20 years, previously it was 10 years or so, we give the patient the option, whichever age they are. Even 30-year-olds, we give them this option now. Because first time we put them through a robotic minimal invasive, then even if they need another procedure in 55, 60 years, there are now transcatheter valves, which I think you discussed over a month ago with our cardiologist. So they can pass valves through angiogram and replace. So that can last further. That way, they can live their life without having anticoagulation. So these options are available now. So that, I think, answers your questions. Sorry, can't hear you.
Yeah, sorry. Here is another question. This person, Dr. Narasimha here, Is the site of the lesion a limitation to MICS?
As I
Can you hear me,
already
sir?
said, with our combination of hybrid, rarely we have to decline minimal invasive robotic procedure as a hybrid. So it's, in very few patients, yes, we may have to. The usual combination that we tend to avoid are very poor heart function with diffuse multiple blockages. Then we tend to, because the outcome, whichever way we do, may not be great. So we may have to do open procedures to choose the right. And most patients now, we are able to offer minimal invasive with the combination of hybrid.
Thank you, doctor. Here is somebody, Rama Subramaniam or Rama Subramaniam. I underwent robotic minimal invasive surgery by Dr. Yusuf on October 20th, or maybe in October 2020, I don't get it. Can I have vaccination for COVID since I am now taking blood thinner?
Yes, yes, please. Usually after
I am sorry, I think.
didn't hear you very well, but
Yeah.
I did get the gist of the question. So she wants to know whether she can take vaccine,
Yeah.
and she's on blood thinners.
Yes.
Yes, please do not stop the blood thinners with antiplatelets and take the vaccine. If it's more than 6 weeks, we tend to advise them to take the vaccine, COVID vaccine.
Doctor, I think we'll just take a couple of more questions. We are running out of time.
Sure.
So here's one person who is 65 years old and he has MVP since birth. Now he's on anti-BP and anti-cholesterol tablets. Is the repair possible by this procedure for his MVP? He wants to know.
Yes. So mitral valve prolapse MVP is present in a significant number of population, but he will need repair. Yes, mitral valve prolapse, 99% of the times will be able to repair, but it needs to be monitored by the patient needs to have the valve repaired or replaced, usually repaired, only if the regurgitation or the leak is more than moderate and if it's symptomatic. Because there are few patients who live with it without much leak, then it's not required. So he needs to be assessed properly by a cardiologist and then a surgeon. If he needs surgery, if he has indications for surgery, yes, we can do it through a robotic or minimal invasive approach, and can more often, as I said, 99% of the time we will be able to repair.
Thank you, sir. I think we'll take this last question and I think we'll have to wrap up after that. So this is Mr. A. Sharif. When the technology has improved so much to have minimally invasive surgery, why do many multi-specialty hospitals prefer to perform angiogram and ascertain the blockage instead of PET CT scan? I think the answer is there in this question, but still you can
Yes.
take it.
Not PET CT scan. PET CT scan is completely different, because that is technical, that looks at more infection or malignancies in places, or it assesses the functionality of the heart. We say viability. So that's completely different. Angiogram is currently the gold standard to assess and treat the blockages are. But currently in Apollo, we have a 640 slice CT, which is very accurate. That we follow that for patients undergoing any other valve procedures where we can avoid angiogram, but it is still currently the gold standard for planning coronary artery disease treatment, either stenting or surgery. Nothing has come superior to that yet. CT is more a screening tool now, and yet we can assess for some patients, but not for everybody. This is the guideline that we have from all the evidence over the years.
Thank you, sir. Thank you so much. This was really interesting, and we have quite a lot of questions. Some of them are your patients themselves, and they want to get in touch with you, I guess. And I think the events team will just forward those questions to you because some have some problem they have some pain in the leg or something like that. So maybe you want to answer them privately. Thank you very
Sure.
much. This was so interesting a session. This was completely new, and the procedure is interesting. I hope lots more people will take it, and we have much more advancements happening in the future.
Thank you. Thanks very much for organizing this. And I'm very grateful to the Hindu group and you, Sujata, for taking it Apollo management for supporting the program. Thank you.